Hello, I'm Ilaria Barchetta from Sapienza University, Italy, and I'm presenting this paper about plasma copeptin levels and NAFLD in people with obesity and type 2 diabetes. So vasopressin is a hormone that is traditionally known to be associated with the regulation of plasma osmolarity, and it has been shown to exert also major effect on glucose and lipid metabolism, and in particular it made it by stimulating hepatic gluconeogenesis, glycogenolysis, and fat production, and it also modulates the release of insulin and glucagon from Langerhans beta cells. So many longitudinal studies have been shown that elevated levels of the stable marker of vasopressin called copeptin are associated with the development and the presence in general of type 2 diabetes and some specific complications of diabetes such as renal function impairment and ocular diabetes complication, and also copeptin levels predict the presence of an increased cardiovascular risk and mortality. So in experimental models conducted on rats, it has been shown that the experimental reduction of copeptin exerted by increasing water intake are associated with a decreased hepatic fat content in obese rats, and that it was independent from body adiposity. However, the association between copeptin and non-alcoholic fatty liver disease and NASH have not been explored in humans. So, starting from that point, we designed this study aimed at exploring the relationship between plasma copeptin levels and the presence of NAFLD, and also to identify relevant correlates of increased copeptin levels in obese patients with and without type 2 diabetes. So for these purposes, we designed this monocentric cross-sectional study, which enrolled 60 obese people candidate to bariatric surgery for clinical reasons, with and without NAFLD and type 2 diabetes. All these patients underwent liver biopsy during their surgery, that was surgery for sleeve gastrectomy in all cases, and circulating copeptin levels were also assessed in 60 age and sex comparable metabolically healthy individuals without NAFLD at the liver ultrasounds. Plasma copeptin concentration were then measured by sandwich immunoimmunometric assay in the laboratory of our collaborators in Lund University of Sweden. So the first result is that obese patients with biopsy-proven NAFLD, so that 53% of the sample, had significantly higher copeptin levels when compared to both control subject and obese subject without NAFLD at the liver biopsy. Plasma copeptin concentration were also associated with hepatic macro and microvesicular steatosis per se, lobular inflammation, and significantly increased throughout degree of NAFLD severity, as expressed by the absence, borderline, or overt NASH diagnosis at the liver biopsy. So, circulating copeptins were also associated with the male sex, as already described in other studies, increased serum creatinine, uric acid, increased waist circumference, and the present component of metabolic syndrome. So, greater circulating copeptin predicted the presence of NAFLD and NASH with an odds ratio of 1.73, even after adjustment for multiple confounders such as age, sex, renal function, and the presence of type 2 diabetes and metabolic syndrome. And the ROC curve, the copeptin levels were able to predict the presence of NASH with an extremely significant area under the curve of 0.822. So, for concluding, we can affirm that this study is the first demonstration of a relationship between copeptin levels and the presence of biopsy-proven NAFLD in obese individuals, regardless of body adiposity and the coexistence of other metabolic diseases. So, increased vasopressin that could be marked by plasma copeptin level measurement may have a direct role in inducing intrahepatic fat accumulation. Therefore, our finding add further knowledge on the metabolic complications which are associated with an impairment of vasopressin and its receptor system and may provide novel insights to possible mechanisms which underline the presence of and the development of NAFLD and NASH in presence of obesity. Thank you.